nervous systems are just too reckless. You know why? Because they do everything on impulse. And you ever wondered, why does the brain experience so much anxiety? Well, it's part of the nervous system. Hi everybody, Dr. Ryan here. I hope you and your family are well. Today we're going to be covering a systematic approach to history taking as it pertains to neurology, and we're going to be covering the cranial nerves. Thanks for joining me. Fasten your seatbelts. Here we go. This is an outline of what we're going to be tackling today. History taking in neurology, we're going to be talking about the neurologic inquiry, touching on risk factors for cerebrovascular disease, and an approach to selected neurological symptoms. And then we're going to tackle examination, right? Handedness, orientation, and speech. We're going to talk a little bit about cortical function, neck stiffness and meningism, and then we're going to touch on the cranial nerves. The neurological examination is just so comprehensive. I don't think it's possible for me to do justice if I cram all the systems into one video. So I'll be making other videos tackling examination of the limbs, and then the basal nuclei and a cerebellar examination, right? So let's get stuck in, guys. In terms of history taking, right, we know that my formula is the mnemonic, perhaps salt makes good food so tantalizingly tasty. Yes. And so the P stands for presenting complaint, the S is systemic inquiry, the M is medical history, G stands for gynecological history, F for family history, SO social and occupational history respectively, T for third party information, and T as well for travel history, right? But we're going to be zooming in to the neurologic inquiry today. So some of the questions you want to tease out in taking a history of neurology. First up, do you have any history of headache or facial pain? Any neck or back pain? And that is coupled with photophobia, because you're asking about symptoms of meningitis, okay? Any faints, fits, or funny turns, right? That speaks to probably a tremor or an extrapyramidal disorder or syncopal episodes or seizures. And with seizures, you gotta ask, was there any tongue biting or any incontinence? Because typically when a patient has a seizure, they bite the lateral surface of the tongue, right? Any associated dizziness or vertigo, any disturbance in vision, hearing, or smell, any difficulty with walking or disturbance with gait. More questions, guys. Any weakness in the limbs? And when we speak to weakness, we speak to it being proximal versus distal. Talk about the symmetry of the weakness and talk about the acuity of onset. Was it a sudden weakness, or was it a more gradual kind of grumbling, insidious kind of weakness? Right? Any loss of or abnormal sensations? We speak about dysesthesia and paresthesias. Disturbance of sphincter control in the way of bladder and bowel incontinence or dysfunction. Involuntary movements or tremor, speech or swallowing disturbance, right? And that fits in with proximal muscle weakness, all right? Any altered cognition. So you got to also, guys, cover for risk factors for cerebrovascular disease, right? And to this end, we speak to the time-honored brothers. Hypertension, smoking, you got to quantify your PACIA history, diabetes mellitus, hyperlipidemia, and of course an appropriate cardiac inquiry in terms of, does the patient have atrial fibrillation, or do they experience palpitations and associated syncope? And then you can do an ECG and tease out whether or not they have atrial fibrillation, which is the most common arrhythmia in clinical practice. Have they had bacterial endocarditis before? They have myocardial infarct before? And by that, we are saying that they may have left ventricular dysfunction with a thrombus. And of course, if that thrombus embolizes, it can lodge and cause a stroke. If they have any hematological disease, we know there are a few of them which predispose to clot formation, so the thrombophilias, like paroxysmal nocturnal hemoglobinuria, protein CNS deficiency, factor V latent deficiency, antiphospholipid antibody syndrome, a couple of them, right? Of course, that is coupled with thrombogenic risk factors. So is the patient taking hormonal replacement therapy? Are they on the pill, right? The oral contraceptive pill, right? And does the patient also have a family history of stroke? Alrighty, let's go on. This is just a diagram from Macleod's demonstrating the lateral surface of the brain. We know that we have 4 lobes. We have, let's just get my pen in there. the frontal lobe, we have the parietal lobe, the occipital lobe, and we have the temporal lobe. And remember that the precentral gyrus is the motor area, and the postcentral gyrus is a sensory area already. Then, of course, below that we have the brain stem, the midbrains, the pons, and the medulla, and we also have the cerebellum. This is a cross section of the spinal cord, right? So we note this is the anterior portion. So let's get my pen in there again. Sorry about that. So we got the anterior portion here, and we've got the posterior portion here. So we've got the spinothalamic tracts, we've got the anterior spinothalamic tract, and the lateral spinothalamic tract, and they subserve the modalities of pain and temperature. All right. Whereas the posterior columns, otherwise called the posterior column medium lemniscus pathway, which consists of two beautiful nuclei here, the fasciculus gracilis and fasciculus cuneatus, subserve the modalities of vibration and joint position sense. Okay, then we also have these other tracts like the posterior spinocerebellar tract. Alrighty, and that's what we talk about in terms of the spinal cord. Okay, just talking about headaches for a bit. So tension headaches, as depicted by this fun cartoon, has the following characteristics. They're usually bilateral with band-like pain that can last for hours or days. This indeed is the most common type of headache, and it is not associated with any focal neurological symptoms or signs, and treatment is with simple analgesia. If not effective, a trial of anti-migrainous agents may be used. The other kind of primary headache syndrome we encounter is migraine headaches. Here we see the pain is often unilateral and throbbing in quality, right? And it has associated photophobia, with scintillating scotomata may occur with or without aura. Typically lasts for a duration of between 4 to 72 hours. Also is associated with phonophobia. You want to consider prophylaxis with beta blockade, tricyclic antidepressants, or valproic acid, or even topiramate. These patients often have concomitant nausea and vomiting, and treatment includes simple analgesia, your serotonin agonists, and your ergotamines. Right, versus cluster headaches, and these are excruciatingly severe unilateral headaches with pain that usually peaks within 10 minutes and lasts up to 3 hours. The orbital, supraorbital, and temporal regions are the usual sites of pain. These patients typically present with ipsilateral autonomic signs, including rhinorrhea, lacrimation, meiosis, and ptosis. First-line prophylaxis is with verapamil, which is a dihydropyridine calcium channel blocker. An acute treatment includes administration of 100% oxygen, serotonin agonists, and ergotamines. So, in teasing out your headache history to ascertain primary versus secondary headaches, so we said that examples of primary headaches are a migraine, tension type. Then also you get the family of trigeminal autonomic cephalalgias, which includes cluster headache. There's also other kinds of headaches that we get, like the primary thunderclap headache, new daily persistent headache, and then we enter into the category of headaches which have a cause, so we call that secondary headache syndromes. And as you can see, there's quite a comprehensive list, including infection, so meningitis comes to the fore, recreational drug use, medication overuse, headaches, head or neck trauma, head or neck vascular disease, and that's where we talk about subarachnoid hemorrhages, like a thunderclap headache, like, the patient says, I feel like someone kicked my head. And cranial neuralgias like trigeminal neuralgia, as well as non-traumatic disorders of head, neck, eyes, ears, nose, teeth, mouth, and sinuses. Now, when you're asking the patient about headache, you want to ask them about the characteristics of the headache. What is it like? Is it dull, sharp, throbbing, or tight? Where do you feel it, at the front or the back, or is it unilateral on one side of the face? How severe is it out of 10? If 1 is not very severe and 10 is very severe, where does this headache rank in terms of pain? And has it begun very suddenly and severely, which probably alludes to a subarachnoid hemorrhage? Do you get any warning signs that it is about to start? This is what we call an aura. Usually happens in the setting of migraine. Some patients see flashing lights or zigzag lines in your vision. Is it associated with sensitivity to light, something we call photophobia, which also speaks to migraine? Do you feel drowsy or nauseated, and that speaks to raised intracranial pressure? Is the pain on one side over the temple? And have you ever had diplopia, which is double vision, pain in the jaw when chewing, which speaks to jaw claudication, and any blurred vision that points to involvement of the posterior ciliary arteries and temporal arteritis? Is the pain getting worse over your cheekbones, speaking to sinusitis. Are the attacks likely to occur in clusters and associated with watering of one eye, speaking to a cluster headache? Is there a prolonged feeling of tightness over the head but no other symptoms? That speaks to tension headache. Do you drink large amounts of alcohol? Last night, did you have an alcohol binge? That could just be a hangover. Okay, here we have causes of transient loss of consciousness. So we have 5 main headings. Okay, it could be syncope in the way of a vasovagal episode. It could be a character sinus hypersensitivity or situational like cough or micturition syncope. Then cardiac syncope, dangerous, right? Then we're thinking about arrhythmias and any form of structural disease, especially the common culprits being aortic stenosis, hypertrophic cardiomyopathy, and pulmonary embolus. Epileptic seizures, which are usually generalized tonic-clonic, and you gotta tease out history of incontinence, history of tongue biting, etc. Postural hypotension with drugs. The main cause is drugs, like antihypertensives, L-DOPA, is it their autonomic failure, or it could be just functional or psychiatric in the way of hyperventilation or a panic attack, or something we call psychogenic non-epileptic seizures, also termed pseudo seizures. And the way you determine whether it's a true seizure or not a true seizure, you can do a prolactin level just after the episode. If the prolactin is high, most likely there was a true seizure. Okay, and here we're just covering, sorry about that, let me just move this across. Features which help to discriminate vasovagal syncope from epileptic seizure. So, in terms of triggers, in vasovagal syncope, these are typically present in the way of pain, illness, or emotion, but in a true seizure, there's often none. Right? In vasovagal syncope, we have prodrome of feeling faint, nausea, tinnitus, or visual dimming, but in a seizure, we have focal onset, but it's not always present. The duration of unconsciousness is typically longer for a true seizure than with syncope. In vasovagal syncope, convulsions may occur, but in the form of brief myoclonic jerks, but in a true seizure, these are usually 1 to 2 minutes in duration and are typically tonic-clonic in nature, right? The color of the patient may be pale or gray in vasovagal syncope because of transient flushing, but in a seizure, red or blue, but can be pale. Lateral tongue biting present in a seizure, not so with syncope. And recovery, very importantly, in vasovagal syncope is rapid with no confusion. But in a seizure, this is gradual over about 30 minutes. Patients are often confused and amnestic. Guys, let's quickly talk about stroke and vascular territories. So if you have affectation of the anterior cerebral circulation, often via the internal carotid, then the clinical features, right, are, as we know, going to be contralateral to the lesion, right? And we often have, the occurrence of primitive reflexes, we have personality disturbance, and we have involvement of the leg more so than the arm contralaterally, right? And involvement of the middle cerebral artery will give us hemiparesis of the face and arm more so than the leg contralaterally, together with hemianesthesia. You'll also, with the MCA territory, in fact, have dysphasia involving the dominant hemisphere, or dyspraxia if it's the non-dominant hemisphere. You'll also have a visual field defect, which is often in the form of phomonymous hemianopia, right? If you have involvement of the posterior cerebral circulation, often via affectation of the vertebral basilar supply, you're going to have features ipsilateral to the lesion, and you usually have a visual field defect in the way of hemianopia, together with ataxia, diplopia, nystagmus, dysarthria, dysphagia, facial weakness and numbness, loss of consciousness, and sensory symptoms. Alrighty, let's just move this across here. Okay, when we're looking at neurological symptoms or syndromes related to drugs, there's a whole bucket load of them, but just to draw out some important ones. Ataxia is commonly the result of anti-epileptic drugs like carbamazepine and phenytoin. Seizures can be brought on by TCAs, for instance, tricyclic antidepressants. A whole lot of drugs cause headache, especially your nitrates. Okay, statins and corticosteroids are famous for causing myopathy. Parkinsonism can be brought on by metoclopramide or neuroleptics. Peripheral neuropathy, especially by our TB drugs, notably isoniazid, which is why we give pyridoxine in combination with that. Chemotherapeutic agents like vincristine, platinum, thalidomide, metronidazole, amiodarone, some ARVs. Tremor can be brought on by beta agonists, especially salbutamol, in our asthmatics and COPDs, right? Lithium and sodium valproate. Examples of inherited neurological disorders, we split them into autosomal dominant, autosomal recessive, X-linked recessive, and mitochondrial. So of the autosomal dominant, there's a lot of them: neurofibromatosis 1 and 2, Charcot-Marie tooth, tuberous sclerosis. Of the autosomal recessive, there's Wilson's disease with Friedreich's ataxia. X-linked recessive, we have Duchenne's and Becker's muscular dystrophy with Fragile X, and some mitochondrial DNA inherited disorders as well. Guys, let's get into examination, the crux of today's talk. So first up, we assess handedness, orientation, and speech. You're going to ask the patient whether he or she is right or left-handed, okay? And then as a screening assessment, you want to ask the patient's name, the present location, and the date. Then you want to ask the patient to name an object that you are pointing at, and then have him or her point to a named object in the room. For instance, you can show them a pen and say, what is this? And then you can point to the curtain and say, what is that? That's a test for dysphasia. Then you want to ask the patient to say a word like British Constitution to test for dysarthria. So dysarthria to determine if there's any abnormal articulation in terms of the way they form their words, right? When you're examining a patient with dysphasia, if the patient has non-fluent speech, it most likely speaks in expressive aphasia, which is a Broca's aphasia, right? So everything is going to be poor, essentially, right? Naming of objects is poor, repetition is going to be poor, comprehension is intact, right? But if a patient has fluent speech, that could be either receptive, conductive, or nominal aphasia, all right, as mentioned. Let's talk a bit about cortical function. So we mentioned that there are 4 main lobes in the brain. Okay, so the frontal lobe, the main claim to fame of the frontal lobe is that it controls your personality, it's the center of your emotions and social behavior, and therefore it makes sense that if you have a lesion in the frontal lobe, you're going to be disinhibited, you have lack of initiative, antisocial behavior, impaired memory, incontinence, you have the primitive reflexes which come back, the grasp reflexes, the pouting, the snout reflex, and anosmia. They are disinhibited, so they don't have any social barriers anymore, right? And they are kind of irresponsible. They go on crazy shopping sprees and they're very impulsive, and that happens in frontal lobe lesions. In parietal lobe lesions, the function of the parietal lobes, we get the dominant and the non-dominant side. The dominant side is responsible for calculation, language, for planned movement, appreciation of size, shape, weight, and texture. So therefore, a lesion of the dominant parietal lobe, you end up with something called Gertzmann syndrome, right? With dyscalculia, dysphasia, dyslexia, apraxia, agnosia, finger agnosia especially, and homonymous hemianopia. But the non-dominant parietal lobe's claim to fame is that it is involved with spatial orientation and constructional skills. Therefore, involvement of the non-dominant parietal lobe will give you neglect of the non-dominant side, spatial disorientation, constructional apraxia, dressing apraxia, and the infamous homonymous hemianopia. The occipital lobe helps us with analysis of vision, and if you have a lesion there, that'll manifest with visual field cuts. So homonymous hemianopia, hemianopic scotomata, visual agnosia. Then you get this thing called prosopagnosia, which is impaired facial recognition. You may have visual hallucinations as well. The dominant lobe, the temporal lobe, there's dominant and non-dominant sides. So the dominant side is responsible for auditory perception, speech and language, verbal memory, and smell, right? And lesions of the dominant temporal lobe will give you dysphasia, dyslexia, poor memory, complex hallucinations in terms of smell, sound, and vision, and homonymous hemianopia. Whereas the non-dominant temporal lobe helps us with auditory perception, music and tone sequences, right? Smell, non-verbal memory, like faces, shapes, and music. If you have a lesion that hits out on your non-dominant temporal lobe, you will have poor non-verbal memory, loss of musical skills for all you musicians out there. Not good. Complex hallucinations, and homonymous hemianopia. So this is just a representation of the homunculus. So you see a lot of the sensory nerve endings have to do with highly skilled movements or sensory perception in the hands and in the face. Okay, neck stiffness. Ask the patient to lie flat and attempt gently to flex the head by placing a hand under the occiput. You also want to flex the patient's hip with the knee bent and then attempt to straighten the leg. So this is what we call Kernig's and Brudzinski's sign. So on the left here is Brudzinski's sign, right, where you're going to test for neck rigidity and you'll see reflex. So as you flex the head, you may see reflex contraction of the hip and the knee, right? because you are stretching those meninges. If it's inflamed, it's going to be painful, and the patient's going to reflexly flex the legs to kind of reduce the tension within the meninges. And here on the right is Kernig sign, right? And the cranial nerves, let's talk about this. Now, the patient should ideally sit over the edge of the bed if possible, and you begin by just stepping back as usual and doing a general inspection of the head and neck. And what you want to look for are craniotomy scars, neurofibromas, any obvious facial asymmetry or hemifacial droop, ptosis, proptosis, skew deviation of the eyes, and inequality of the pupils. Now, this is a very fun representation from MedComic.com. Thank you so much to Mr. George Muniz and company. A fun representation of the different cranial nerves. So one, as we know, is, let's just get my pointer in there. So one, as we know, is like olfactory, so that's the nose. 2 is optic, so that's the eyes. Then 3, 4, and 6, as we know, are concerned with control of extraocular eye movements. So we can say 3 here, 4, and 6. And 5 is a trigeminal nerve, right? Which you can see a big 5 here, right, for trigeminal. Right, 7 is the facial nerve, as we can see. 8 is concerned with the acoustics, right? The 9th and the 10th are the glossopharyngeal and the vagus. The 11th is responsible for innervation of the trapezius and the sternocleidomastoid, and the 12 is a hypoglossal. Very, very, very nice. So let's get into each of these nerves and spend some time on them. Okay, so with the second nerve, you want to test visual acuity. You test the fundi and the fields, right? So there's 3 things. You want to test visual acuity with the patient using his or her spectacles, right? And each eye is tested separately while the other is covered with a small card. You want to examine the visual fields by confrontation using a hat pin or fingers. The examiner's head should be level with the patient's head, and each eye is tested separately. If indeed the visual acuity is very poor and the fields are mapped using the fingers, then of course you want to look into the fundi. So this is an example of visual field testing. So if you're testing the patient's right eye, right, then you got to cover your left eye, right? And you use a hat pin and you approach from outside the patient's field of vision. You come in with a hat pin and ask the patient when they can first see it, arrive in their field of vision from each of the 4 quadrants, right? And by so doing, you're mapping out the visual fields to see if there's any particular field cut. So this is a representation from Talley and O Connor of the visual pathway. So you know that we have, in terms of the visual fields, we have temporal and nasal fields, right? And this is the retina. And from the retina, we have the optic nerve, right, which then converge, and this decussation of fibers that occurs at the optic chiasm. After that, we have the optic tract, and thereafter the optic radiation, which projects into the occipital lobe, right? So cuts at strategic points in the pathway will give particular kind of deficits. So if you have involvement locally within the eye at point number 1, then you can have concentric diminution of the field. Examples of that: glaucoma, papilledema, syphilis, right? And syphilis also gives you the Argyll-Robertson pupil, which we'll talk about later. And then number 2, if you cut at the level of the retina, then you have an enlarging blind spot, right? If you have a cut along the optic nerve between the retina and the chiasm, you end up with central scleromata. And typical examples of those is demyelination disease, toxins, vascular, nutritional. All right, if you have a cut of the complete optic nerve on one side, you end up with unilateral field loss. Typical examples of those is vascular and tumor. All right, some of the more common visual cuts that we see, or visual field cuts, is bitemporal hemianopia, which happens when you have an optic chiasm lesion, and the typical example is a pituitary tumor or a stellar meningioma. Yeah, I'm selling that one, stellar meningioma. Right? And if you have a cut at the level of the optic tract, then you end up with homonymous hemianopia, which is a cut between the optic tract and the occipital cortex. Classic examples of that: vascular lesions and tumors. Remember that incomplete lesion results in macular sparing. Right? If you have a cut at the level of the optic radiation, you end up with a pie in the sky or the pie on the floor, which speaks to upper quadrant homonymous hemianopia, so-called pie in the sky, which speaks to a temporal lobe lesion, especially by a tumor or an infarct. And if you have lower quadrant homonymous hemianopia, so-called pie on the floor, that speaks to a parietal lobe lesion. Alrighty. Let's move on to the 3rd, 4th, and 6th nerve. So next, you want to look at the pupils, noting the shape, the relative sizes, and any associated ptosis. You want to use a pocket torch and shine the light from the side to gauge the reactions of the pupils to light. That's a direct response. And you also want to check the consensual response as well. Then you swing the torch in an arc from pupil to pupil, looking for an afferent pupillary defect, all right? And that's otherwise called a Marcus gun sign. You also want to test the combination by asking the patient to look into the distance and then at a hat pin or finger held about 30 centimeters, which is like a ruler's length away from the nose. And by that, you're trying to test accommodation, okay? You want to assess the eye movements with both eyes first, getting the patient to follow the pin in each direction. You also want to look for failure of movement of a nystagmus and ask about diplopia in any particular direction. So here we can see how we inspecting the direct response to light. So you should see, as you shine the light from this side, you should see pupillary constriction. So the sensory pathway for this is the second nerve, and the efferent pathway is the third nerve. Alrighty. So here we can see, let's just move this, sorry about that. Right, the functions of each of the individual nerves. So the maximum for this is SO4, LR6, R3. So the superior oblique is responsible for innervation of the fourth nerve, which intorts the eye. It intorts the eye. Therefore, patients who have fourth nerve palsies typically complain about difficulty walking downstairs because they cannot move their eye down and in. That's intorting the eye. The lateral rectus, LR6, is innervated by the sixth nerve, which is responsible for abducting the eye. All other eye movements are taken by the third nerve. The third nerve also supplies the levator palpebrae superioris, and the claim to fame of that muscle is that it lifts the eyelid up. Therefore, in a third nerve palsy, you end up with drooping. We'll talk more about that, right? So here we're assessing the eye movement. So here we're asking, look to the left. So B is look to the right. So C is look up and D is look down. So thus testing the different extraocular eye movements, right? So we spoke about the mnemonic for SO4, LR6, R3 and what that stands for. In the setting of cranial nerve 3 palsy, a handy way to remember that is the mnemonic 4 Ds. So D for dilated pupil, D for diplopia, D for divergent squint, and D for the drooping eyelid, which speaks to ptosis. Fifth nerve. So here you want to test the corneal reflexes gently and ask the patient if the touch of cotton wool on the cornea can indeed be felt. The sensory component for this reflex is the fifth and the motor is the seventh, right? Then you want to test facial sensation in 3 divisions, the ophthalmic, maxillary, and mandibular. Then you want to test pain sensation with the pin first and then map any area of sensory loss from dull through to sharp. You also want to test light touch as well so that any sensory dissociation can be detected if present. There's also the motor division of the fifth nerve. So you ask the patient to clench the teeth while you feel those masseter muscles. Then you get the patient to open the mouth while you attempt to force it closed. And this is not possible if the pterygoid muscles are working. So open your mouth. Right? A unilateral lesion causes the jaw to deviate towards the weak or the affected side. You then want to test the jaw jerk, which happens to be exaggerated in cases of cerebral palsy. So this is the nice diagram from Macleod illustrating the different divisions of the trigeminal nerve. So we spoke about number 1 being the ophthalmic division, number 2 the maxillary, number 3 the mandibular division. And this is time to illustrate the jaw jerk in someone, which we said is exaggerated in cases of cerebral palsy. Let's move on to the seventh nerve, guys. We're shifting gears. Test the muscles of facial expression and ask the patient to look up and wrinkle the forehead and then look for loss of wrinkling and feel that muscle strength by pushing down on each side. Now, this is preserved in the upper motor neuron lesion because of bilateral cortical representation of the muscles in this area, right? Next, you want to ask the patient to shut the eyes tightly and compare the two sides. Tell the patient to grin and compare the nasolabial folds, all right? So this is how you test for motor function of the seventh nerve. So in picture A, we're asking the patient to raise his eyebrows. In picture B, show me your teeth. In C, you ask him to close the eyes against resistance. And D, asking him to grow out his cheeks, alrighty? So this is typically what we see in upper and lower motor neuron lesions. So in picture A, what we see depicted is a right-sided lower motor neuron lesion, in that you can see that all the muscles of facial expression are affected on the right? And we also have Bell's phenomenon. So you ask him to shut his eyes, but his eyes can't actually close, and we have movement upwards of his eyeball. That's what we call Bell's phenomenon, right? But note here, on the right-hand side, in picture B, we have a right-sided upper motor neuron lesion. So we have affectation of the muscles only in the lower half of the face. We have sparing of the forehead muscles because we said the forehead muscles receive bilateral cortical representation coming from the cortex. Eighth nerve, you softly whisper a number 60 centimeters from each ear. 99. 99. Then you examine the external auditory canals and the eardrums if this is indicated. Okay, so we can use I think it's 128 hertz tuning fork. Oh no, it's 256 hertz. Yeah. No, it's 128. Actually, I gotta check that out. But we do the Weber and the Rene test, right? So you basically, what you're gonna do is you're gonna activate the tuning fork, create a sound. You place it over the bones, just behind the ear, and ask the patient to tell you when they can hear it no more, and then you place it just outside the ear, right? So normally the note is audible at the external meatus, but in the case of nerve deafness with an eighth nerve palsy, the note is audible at the external meatus as air and bone conduction are reduced equally, so that air conduction is better as is normal. That is what we call Rene positive. But if there is middle ear or conduction deafness, then no note is audible at the external meatus, and that's Rene negative. Right, and then Weber test is where we activate the tuning fork and place it over the center of the forehead, and you ask the patient, is the buzzing louder on one side? So normally it shouldn't be loud on one side. If there's nerve deafness, the sound is louder in the normal ear, but if there's conduction deafness, the sound is louder in the abnormal ear. Regarding the 9th and 10th nerves, everybody, you want to look at the palate and note for any particular uvular displacement. Ask the patient to say, ah, and look for symmetrical involvement of the soft palate. With a unilateral lesion, the uvula is drawn toward the normal side. So this is the one that doesn't fit convention. Normally, we have, if there's weakness, it's going to deviate towards the affected side. But here, the uvula is drawn toward the unaffected or the normal side. You want to test gently for sensation of the palate. That's the 9th nerve. Ask the patient to speak to us. Says, hoarseness, voice, and to cough. Right? A bovine cough suggests bilateral recurrent laryngeal nerve palsies. So here we're testing the 10th nerve. We're saying and look for asymmetrical movement of that uvula. The 12th nerve, which is a hypoglossal nerve, so while examining the mouth, inspect the tongue for wasting and for circulation. Next, ask the patient to protrude the tongue. With the unilateral lesion, the tongue, as we know, deviates toward the weaker or the affected side. So stick out your tongue, look for deviation, right? So here we can see a right hypoglossal nerve palsy, a lower motor neuron lesion. I'm saying stick out your tongue and note that tongue, whether it's spastic or whether it's flaccid. Note for any fasciculations in the tongue as well, right? In the 11th nerve, you look for torticollis and ask the patient to shrug the shoulders and feel the trapezius muscles as you push the shoulders down. Then ask the patient to turn the head against resistance and feel the bulk of the sternocleidomastoid muscles. Examine the skull and auscultate for any carotid bruise. So this is how we examine the trapezius. So shrug your shoulders, sir. Let me feel the strength in there. And then turn the head against resistance, all right? So guys, I just want to illustrate the clinical features of bulbar versus pseudobulbar palsies, right? The characteristics we look at is the gag reflex, the tongue, the jaw jerk, speech, and other causes. So cerebrovascular palsy speaks to bilateral upper motor neuron lesions of 9th, 10th, and 12th nerves. Bulbar palsy is bilateral lower motor neuron lesions affecting the same nerves, right? So you do your gag reflex, and your gag reflex is normally going to be it's increased in a cerebrovascular palsy, or it could be normal, but it's usually absent in the setting of a bulbar palsy. In a cerebrovascular palsy, the tongue is spastic, the jaw jerk is increased, the speech, we have spastic dysarthria, right? And other causes are things like bilateral limb long tract signs, together with labile emotions, bilateral cerebrovascular disease with involvement of both internal capsules, multiple sclerosis, motor neuron disease. But in the setting of bulbar palsy, we said the gag reflex is absent, the tongue is wasted with fasciculations, the jaw jerk is absent or is normal, speech is nasal, and other causes are signs of the underlying cause, like you may have limb fasciculations, you have normal emotions, we have examples of cause, motor neuron disease, Guillain-Barré, polymyelitis, and brainstem infarct. Sometimes cranial nerve palsies happen in groups, and when they happen, classic example is nasopharyngeal carcinoma, chronic meningitis, what we call complicated meningitis. For instance, if there's underlying carcinoma, TB meningitis often presents with multiple cranial nerve palsies on account of raised intracranial pressure. Sarcoidosis can do the same. Guillain-Barré sometimes spares the sensory nerves, or actually always basisensory nerves, but it can give you this phenomenon called polyneuritis cranialis with the involvement of multiple cranial nerves. There's also the proximal version of Guillain-Barré, which is called Miller-Fisher, where you end up with ophthalmoplegia, ataxia, and areflexia. Brainstem lesions can do the same, especially patients who have cerebellopontine angle tumors, Arnold-Chiari malformation, mononeuritis multiplex sometimes as well. So this we've been through already, bulbar versus cerebral palsy. So guys, this is just a quick summary of what we just discussed. So the first nerve concerns, the olfactory nerve, concerns itself with smell and abnormalities would manifest with anosmia or parosmia. The second nerve, we said we test the visual acuity, the fields and the fundi. You're looking for the pupil, the size and shape. You're looking for the direct and consensual responses and accommodation, and do your fundoscopy. So abnormalities would be partial blindness, scotomata, hemianopia, and isochoria, and obviously you can have changes in the fundi. And the third nerve is responsible for the accommodation reflex, which is impaired or lost if there's a lesion of the third nerve. Also, third, fourth, and sixth control extraocular eye movements, which is responsible for controlling your eye position and movements. And lesions here will give you strabismus, diplopia, and nystagmus. The fifth nerve, we have ophthalmic, maxillary, and mandibular sensory divisions. It is responsible for innervating the muscles of mastication, the pterygoid and the masseter muscles, and this is going to be lost in a lesion of the fifth nerve. Seventh nerve controls muscles of facial expression and taste over the anterior 2/3 of the tongue. Lesion will manifest with ageusia and facial weakness with hemifacial droop. The eighth nerve, we test with whispering and tuning fork test, the Rene and Weber test, as well as vestibular tests. And if you have abnormality in the eighth nerve, it manifests with impaired hearing and deafness, together with nystagmus and vertigo. The ninth nerve is responsible for observing pharyngeal sensation and sensation from the posterior 1/3 of the tongue, not routinely tested. The 10th nerve controls movements of the palates, which may be impaired uni or bilaterally in a lesion of the 10th nerve. The 11th nerve, think about the chaps and the sternocleidomastoid. Right, and that manifests with weakness of neck movement. And the 12th nerve observes the tongue, so tongue appearance and movement. And the lesion of the 12th nerve, you end up with dysarthria and chewing and swallowing problems. The mnemonic is O, to touch and feel. Very good, Velvet. Ah. So the first nerve is the olfactory, the second is the optic nerve, the third is the oculomotor, O, to touch and feel. Fourth is the trochlea. Fifth is the trigeminal. Sixth is the abductions, right? There's some brain block there. The seventh is the facial nerve, touching. Very good. Velvet is the ninth and 10th. The eighth is the acoustic nerve. Ninth and 10th is the glossopharyngeal and the vagus. The 11th is the accessory, and the 12th is the hypoglossal. Okay, I hope you allow me to just encourage you from the Word of God. I want to speak about living in the Spirit. In the book of Galatians chapter 5, verses 16 through 17 tells us, this is what Paul is telling the church in Galatia. So I say, live by the Spirit, and you will not gratify the desires of the flesh. For the flesh desires what is contrary to the Spirit, and the Spirit what is contrary to the flesh. They are in conflict with one another, so that you do not do whatever you want. So in this nature, beloved, we have a carnal, fleshly man who desires the pleasures and the lust that the world has to offer. And then we have the Spirit man who wants to obey the Lord and do that which is right. And I pray that, we will draw close to God, and we will seek to crucify the flesh man so that we can be obedient to the unction and the instruction of the Holy Spirit in our lives, to live holy lives which are pleasing in the sight of the Lord. These are my references. God bless you. I'll see you soon with our next video where we talk about neurological examination of the limbs. See you there. God bless.